With the passing of the Health Information Technology for Economic and Clinical Health Act in 2009, the use of the electronic health record, or EHR, has become the norm in all healthcare settings. The electronic health record, for the most part, has been a very good and useful tool to use in healthcare. However, it does have some drawbacks. This presentation is going to address some of the legal and ethical issues which can arise with the use of the electronic health record. The specific issues covered in the presentation will include the use of best practice alerts, or BPAs, point of care or real-time documentation as opposed to retrospective documentation, individualizing care plans, documenting patient and family education, and the potential dangers of utilizing the copy and paste feature included in most electronic health records. Using socio-technology theory, it can be surmised that the introduction of technology creates change in an environment, creating supposedly better delivery of service. However, there can be some unintended behaviors which may be seen as an undesirable result of the new technology. There are documented behaviors of staff which may actually compromise patient safety. These behaviors may cause a staff member's professionalism as well as their level of accountability to come into question. Before we delve into some of the legal and ethical challenges associated with the use of an electronic health record, let's discuss the advantages, which are many. The ability to access a patient's medical record from any computer terminal equipped with the related hardware makes for ease of updating records, accessing needed test results, having current medications available, as well as any allergies. By utilizing e-scripts or electronic prescriptions, the chance of a mistake occurring due to illegible handwriting is greatly decreased. Also, adverse drug reactions can be decreased when the electronic health records are linked to pharmacies and drug banks. With the ability to store records in the cloud or on a facility electronic records system, the need for physical space to store the mountains of paper charts which accumulated is eliminated. The medical records can also be easily accessed for the purpose of research, with patient approval and data extraction. Best practice alerts have been initiated in many institutions to alert staff to evidence-based protocols such as malignant hyperthermia, increased fall risk, communicable diseases, and sepsis, to name a few. While these BPAs are very useful, they can give rise to certain ethical issues if critical thinking is left out of the decision-making process. McBride et al. Cites a case scenario involving a patient with a history of heart failure who presented to the ED afebrile, oxygen saturation of 88% on 4 liters of O2 per nasal cannula, a respiratory rate of 30, and a heart rate of 110. Because of the patient's vital signs, the sepsis BPA fired and the provider initiated the sepsis protocol. The nurse caring for the patient had taken care of him for the past 10 years and was well aware of his history of heart failure. When she approached the provider with her concern about this being an exacerbation of his heart failure instead of sepsis, the provider states, "If we don't follow the protocol, we may fall out of the sepsis quality metric for the hospital." The patient suffered a respiratory arrest related to pulmonary edema, resulting in him having to be intubated. He was later diagnosed with an acute onset of fluid overload secondary to the rapid administration of the fluid boluses. It was further determined he was not septic. This case study is the perfect example of the ethics involved when decisions are made not on clinical judgment, but on simply following a BPA because you fear being called out for not following a protocol. It should be noted that the nurse in this scenario experienced a great deal of moral distress due to the situation. The ideal case scenario would be one in which the nurse could complete a patient assessment or admission and then immediately, while still at the bedside, complete the required documentation. The reality is nurses often find it difficult to document everything at the bedside due to patient demands and must chart later using a retrospective time. The risk with this type of behavior is the possibility of inaccurate documentation. One example, which occurred at the institution where I currently work, is the wrong data can be entered. The previous practice was for the CNAs to perform a fingerstick blood glucose, write the result on a sticky note, and then enter it into the patient's electronic health record at a later time. However, we had an instance where the CNA gave the RN the blood glucose results on a yellow sticky note with the incorrect patient's blood glucose reading. This practice resulted in a patient receiving a dose of insulin based on the blood glucose result of another patient. The patient who received the insulin ended up suffering a hypoglycemic episode just a few hours later. Because of this incident, our policy and practice is to now record the blood glucose result in the electronic health record while still at the patient bedside. With the advent of accountable care and the Centers for Medicare and Medicaid Services meaningful use reimbursement, healthcare providers are required to prove they have provided both patients and their families with the necessary education. The expected outcomes from meaningful patient and family education are increased patient satisfaction, lower healthcare costs, as well as an improved quality of life for the patient. If an institution fails to provide meaningful education, the amount of reimbursement from CMS could be affected. Many electronic health record programs allow the care provider to access patient education materials which can be printed out without having to go to any outside sources. Unfortunately, in the busy rush of caring for a team of patients, I fear nurses are not providing the amount of patient education necessary to meet these goals. Nurses who deliver care at the bedside are tasked with so many chores, requirements, and expectations, making it difficult to spend a significant amount of time with individual patients and families. The end result is patients and their families who don't have a complete understanding of their disease process and plan of care, possibly causing frequent readmissions. I truly feel many patients who are labeled non-compliant are actually ill-informed. Meaningful use also applies to the plans of care. The CMS requires documentation in the plan of care which reflects patient and family engagement standards. No longer can a nurse pull out a congestive heart failure plan of care, as an example, and put a patient label on it and sign it. Plans of care must be individualized, meaning the patient's name is added into the goals and outcomes. Also, the nurse must select only those things which apply to each individual patient. In addition, the patient and family must be included in making the plan of care, giving them a chance to buy into the treatment plan, giving them a vested interest. This is at the very heart of patient and family-centered care, which is a driving force behind many mission statements of healthcare organizations today. Patient and family-centered care has been proven through research to increase patient satisfaction, reduce complications, decrease unplanned readmissions, as well as devise genuinely patient-centered solutions. Another issue related to the electronic health record, which has come to light, is the use of the copy and paste feature allowed by most electronic health record programs. It can be very tempting to copy and paste assessments, history and physicals, and even medication lists instead of performing real-time documentation. There is evidence which suggests there is a very high rate of using this feature in all aspects of medical documentation. The use of this feature can result in inaccurate data being entered into the patient's medical record, thereby increasing the risk for patients and liability for clinicians and organizations. As a clinical educator, I make it a point to discuss this very topic, not only in staff nurse orientation, but also in the nurse residency program in which I teach. I highly discourage the use of copy and paste, highlighting the fact of committing possible documentation fraud by documenting activities which never occurred. I have done many chart audits in which I have come across instances which the nurse or CNA has used the copy and paste feature to document daily care. When you look at this flow sheet and note that the patient was provided oral care every hour of a 12-hour shift, you become somewhat skeptical. I try to impress upon the nurses I instruct the importance of documenting accurately, as well as the fact that the electronic health record is in fact a legal document, which can be pulled into a court of law. The advantages of an electronic health record are many. However, the accessibility of the protected patient information is greatly increased over what a paper chart would have been. In the past, to access a patient's chart, one had to go to medical records and have the document pulled. Now, with the electronic health record, any healthcare professional with access to the electronic health record system can pull up any patient's data at any time. The difficulty lies in determining who should have access to a patient record. According to Ozair et al., only those who require the information in order to care for the patient should have access to the chart. Most institutions employ safety officers whose job is to monitor those persons who are accessing patient information. In order to prevent an unauthorized user to access protected patient information, no one should share passwords or leave a computer unattended with a patient's medical record open. Another point worth mentioning is the need for encryption software to be installed on any device used to access patient medical records, including cell phones and tablets. The hospital I work at takes these security measures very seriously and routinely conducts audits to ensure only those directly involved in a patient's care are accessing the medical record. Not long after we went live with our current electronic health record, one of our pediatric nurses was fired for looking at a fellow employee's medical record without prior authorization. Throughout this presentation, we have discussed the many advantages of the electronic health record, such as accessibility and accuracy. Remember, the use of built-in programs, such as BPAs, do not replace critical thinking when it comes to directing patient care. We have also discussed the need to chart patient assessments, medications, and point-of-care testing at the bedside in real time. Using CMS guidelines for meaningful use, we must remember to individualize all plans of care as well as education, including both the patient and family in their creation. We have also discussed some of the ethical issues presented by the use of the electronic health record, such as utilizing copy and paste, potentially documenting incorrect information. We must be mindful of protecting the patient information by ensuring we never leave a computer terminal with an open chart visible to anyone who may be in the area. Medical providers should always ensure they are not sharing private patient data utilizing a device not equipped with encryption software. It can be so tempting to look up a family member's or our own lab results, imaging results, or history and physical just because it is accessible. This is a HIPAA violation which could result in disciplinary action. We must always consider if we have a need to know before we access someone's medical record. The electronic health record is a wonderful tool when used as intended, but it does carry with it added responsibility for healthcare providers. I consider it my job as a clinical educator to instruct all my new staff nurses, as well as graduate nurses, on the advantages as well as the pitfalls created by its accessibility.